Good afternoon. My name is Kyle Griffin, and today we'll be discussing argininemia. Now, it's important to realize that there are several different names by which this disorder goes. ARG1 disorder, which denotes a specific gene that causes the disorder. Arginase deficiency, which denotes that there's deficiency of the arginase enzyme. And hyperargininemia, which displays that there is a buildup of arginine in the body system. So to begin, let's discuss a case study of a child who presents with argininemia. An 18-month-old female presents to the emergency room with a previous history of flu, was onset a month ago and is currently resolved. Her patients are of a religious belief that does not allow for genetic testing or post-birth testing of newborns. Her present illness presents with hyperemesis, low-grade fever, acute onset of seizures, failure to thrive, and elevated blood ammonia. Now, apart from seizures and elevated blood ammonia, this would appear to be something similar to a bacterial infection, and oftentimes arginase deficiency is missed upon initial evaluation because of these factors. The disease can occur, the disorder can occur in children who are between the ages of 6 months up to 18 years. So, hyperarginemia was first discovered by Tarragon et al. He conducted a research study that involved 3 different children of 3 separate families who all displayed symptoms of argininemia. He conducted this research in 1975, so this disorder is fairly recent in terms of when it was discovered. He was a German scientist, and the picture on the right is the children's hospital where he carried out the research on the first cases of hyperargininemia. So, one specific characteristic of all 3 families is that the children came from consanguineous parents. The children also displayed symptoms of stunting, spastic dysplasia, and epilepsy. These are all hallmark signs of the disease, as the children develop ataxia and are also of a shorter stature than would be expected for children their age. Another diagnostic factor is that all children were found to have abnormal levels of arginine in their blood, which led to elevated ammonia, and this is what led Tarragon to believe that the urea cycle was perhaps the effect of this disorder. Now, this disorder is quite uncommon, and current estimates state that roughly 1 in a million births will produce a child with argininemia. So the molecular manifestation of this disease is actually up to 40 mutations of the ARG1 gene, which is located on chromosome 6. And as you'll see, there's a red mark in the normal urea cycle to your right. That red mark is where arginase, the enzyme coded for by ARG1, plays a role in removing a nitrogenous base from arginine and creating urea, or a component of urine. If there is an alteration in the ARG1 gene, and this causes arginine to actually build up in the body and cause a basic environment, as would be from the buildup of the nitrogenous base that arginase is no longer there to remove. Because of this mechanism, this is why we see the effects of argininemia, and specifically its effects on the nervous system. So as for inheritance, this is an autosomal recessive disorder. Therefore, you would have to have 2 recessive alleles to display this disorder. Now, also what makes that dangerous is it can be hidden in the parental generation by being heterozygous for the disorder. So 2 parents could be carriers and perhaps pass this on, a 1 in 4 chance, to their child. So here we see a pedigree where the arginase deficiency carrier status is denoted by the small red circle. And you'll see that there are several generations of carriers until this disease actually becomes present in the population with Frankie. And then the disease can continue, or the disorder can continue to spread to subsequent generations. Now, this creates a problem for testing and determining whether or not someone is a carrier or if a child actually has this disorder, because as noted by Terrigan, it can take years for this to develop and promote clinical symptoms. Therefore, for testing avenues, carrier testing is one of the most important. It's important for parents to understand whether or not they're carriers of this disease if they're known to have a family history of this disorder. Another important genetic testing or newborn testing is dried blood spot, which is conducted in all 50 states on children when they're born to test for certain genetic abnormalities or genetic disorders, specifically metabolic disorders such as the urea cycle. Now, in the case of our 18-month-old child, the parents had opted not to undergo newborn testing, so the syndrome was potentially missed, depending on if that state mandated that argininemia testing was required for newborns. Now, if a state does not require such testing, then whole exome sequencing would be the next step to determine whether or not a child would present with this condition, which is of utmost importance for treatment, as these children need to be limited in their protein intake. Children who are limited in protein intake will not manifest clinical symptoms because there will not be a nitrogenous base to remove from arginine in the urea cycle. In closing, these are the sources which are used for this presentation, and if you'd like to see them, I'd advise you to. Thank you so much for your time.